Hi, welcome to episode 4 of the Healthcare Triage Podcast. I'm your host, Aimee Carroll. We're very excited that you're continuing to join us. As always, we're looking for your questions. Those can be entered at healthcaretriage.info. We're going to be answering many today, but we always could use more. So go now, well, not right now, but when you're done listening, and enter more questions at healthcaretriage.info. My guest this week is a nurse practitioner. Many of you all the time are asking us questions about what mid-level practitioners like nurse practitioners do. And while I somehow hem and haw and try to come up with a good answer, we thought we would go right to the source and ask one herself. So joining us will be my wife, Aimee Carroll, a nurse practitioner. But before we get to that, let's talk about some things that are in the news this week. The biggest change is probably the fact that, depending upon when you're listening to this, they've passed the tax reform or tax reductions that the House and Senate Republicans and even the president have been talking about for some time. The biggest change with respect to news and healthcare is that it appears that they might have gotten the individual mandate repealed as part of that. How big a deal that is really unknown. People like me have been arguing for years that you need the individual mandate or something like it in order to incentivize healthy people to buy into the insurance exchanges. Because without it, if you have community ratings, if you have guaranteed issue, and you have subsidies, you really don't need to buy insurance until you get sick. And so you could wait until you need it and then buy the insurance. And while it might be risky and cost you some money in that first year, they can't deny you the insurance. They can't charge you more because you're sick, so you could still make out pretty well. To avoid that kind of gaming, which can lead to what we also call a death spiral, we need some kind of means to induce healthy people to buy insurance. One way is to charge them a penalty or a tax if they do not buy insurance. And that, of course, is what the individual mandate is. I've actually argued for years that the individual mandate isn't severe enough. There are other things we could do, of course, to get rid of this as well. We could have different kinds of open enrollment periods or penalties or lockout periods. And it doesn't have to be a mandate. But regardless, if they get rid of the mandate, we are somewhat in a new place that we don't know how it's all going to function. It's possible everything will be okay. It's possible it could be a nightmare. What's very likely to happen, though, according to most analyses, is that a significant number of people are not going to buy insurance. They will be uninsured, which will save some money in terms of subsidies, which is, of course, how they can plow that in to reduce the cost of the tax bill. Uncharted waters. We're going to have to see what happens. The other big news, which has been lighting my Twitter feed on fire this week, has been some controversial documents that seem to have gone around to CDC and elsewhere that seem to ban certain words from being used in budget documents. And while this made a lot of news at first, the follow-up news has been a little less severe. Originally, people thought that certain words like transgender, fetus, and others were being banned from use. Others thought that words like science-based or evidence-based were being told that they couldn't put in documents produced by the government. It seems, and it's totally not clear yet, but it seems that this might have been more suggestions that some career people were saying that might be useful in order to try to get your budget approved by more political people. In other words, this might say more about the people who were producing the documents than it might about the people who were reading the documents, that they thought removing these words might make things flow more cleanly. It's also possible that these were mere suggestions by small numbers of people and not necessarily real changes in how we're going to speak inside the government. Regardless, it was chilling to many people, the idea that we might actually have words forbidden, especially when they are words like science-based and evidence-based and have to do with science, which is probably why they drove my science-based friends out of their minds on social media this week. Let's get to our guest. Our guest, Aimee Carroll, is a pediatric nurse practitioner. She's also my wife of almost 20 years. And she is joining us this week to talk about what it's like to be a nurse practitioner. How do you get to be a nurse practitioner? What does a nurse practitioner do? And what does she do specifically? So, Aimee, welcome to the program.
Thank you for having me.
So tell me, when did you decide you wanted to be a nurse practitioner?
Well, after I finished my 4 years of nursing school, I realized that I needed something more and that I didn't really want to do inpatient nursing.
So when made you know you wanted to go to nursing school?
Well, that's a great question. I think it was suggested to me by my family members. But now that I think about it, I really do enjoy taking care of people. So in the end, I think it all worked out.
So you went to University of Michigan and your 4-year degree was then you earned a bachelor's of nursing?
So 4 years was bachelor's in science of nursing. And then I decided, you know what, I kind of think I need a little bit something more. I wanted a little more independence. I decided that I wanted to take care of patients on my own and not just to do inpatient nursing. So I decided to do a primary care nurse practitioner degree for pediatrics.
And what do you have to do to get that degree?
I did a master's. I did a program that was actually an expedited program at the University of Pennsylvania. At that point, it was a 13-month program. And that gave me the ability to practice on my own, prescribe medication, see patients independently, and in addition to having a collaborative agreement with a physician.
So can you explain to me the difference between what you would have been able to do as a nurse with a bachelor's of nursing and a nurse practitioner with a master's degree?
Well, to be very honest with you, I spent very little time practicing just as a bachelor's in science of nursing. Between my undergraduate and graduate school, there usually is a couple of years where you practice out in the field, but I was accepted into a master's in science and nursing program with only a summer in between my bachelor's and my master's. So I practiced primary care. I did a lot of triage for an OBGYN office. So it was basically doing vitals and checking patients in and triaging phone calls. But that was my limited experience as with my BSN.
So what is the difference between the nurses you work with now, what they do, and what you do as a nurse practitioner?
Well, they can't diagnose, and they can't treat, and they can't prescribe any medication. So what we're doing, I work in a school-based health clinic. So they're basically doing vitals and doing a lot of screening questions in the school, and then I do the intake, asking all the questions, doing the physical exam, diagnosing and prescribing, which they can't do any of.
So what do you think the difference is then on the other side between, say, a nurse practitioner who's working in an office and a doctor who's working in an office?
There are times when there are unique diagnoses that I'm not exactly sure what something is. And at that point, I have two amazing physicians that I work with that are specifically in adolescent health that I can call that will either come to the school or do a consultation on the phone. But for the most part, I think I operate very similarly in the school to how a doctor could within the realm of, being at a school. Because we can't do everything in a school that we could do in a clinic. But I think inside the school, I operate pretty much like a physician would.
So I want to talk about the school, but I want to go back because before you worked in the school, you worked in an office.
Correct.
Where you were functioning as a nurse practitioner in basically a pediatrician office setting. So what was the difference then between what you did every day as a nurse practitioner and what the doctors would do?
I didn't round on patients in the hospital,
okay,
and I couldn't admit patients to the hospital if I felt that they needed it. I would ask for a consultation from one of the physicians. But otherwise, inside the primary care office, I operated pretty much just like the physicians did.
Did they have to see your patients as well, or did you see them on your own?
I saw them on my own, unless I had a question. I think in the beginning, when I first started out, I was new, so they wanted to come in and sort of double check a little bit. But once they realized that I was pretty competent, then they let me go on my own, and it was really based on my comfort level.
And could you prescribe drugs?
Yes.
Which is interesting. Now, of course, I'm coming from the doctor perspective. So I live in both of these sides of the world. So I hear often from my doctor friends that, well, you just don't have the same kind of training. You haven't been in school as long. You didn't have to go through residency. So how is this possible? So when you hear things like that, how do you respond?
Well, to be honest with you, I'm very cognizant about what I will prescribe and to whom. I feel comfortable prescribing antibiotics, routine medications. We do birth control, but I'm not going to prescribe a medication that I don't normally prescribe. Like if a student has or a patient has high blood pressure, that's not something I feel comfortable doing on my own. So I won't prescribe medications unless I consult with a physician if it's not within my comfort level.
And I'd also say probably the vast majority of what you see is bread and butter pediatrics. It's well-care visits. It's ear infections. It's sports physicals. It's the same things over and over and over again. How often do you feel like you come up against people who have a bias against nurse practitioners? Is this something only in the medical field or in the general public as well?
I feel like I'm very well respected in my school and in the primary care practice that I used to be at in Philadelphia and in Seattle. I don't ever feel like people have disrespected. I mean, if I made a poor judgment call,
Sure,
you could disrespect me. But I'm always I'm very aware of my limits and what I feel comfortable diagnosing without supervision.
So where are common places that nurse practitioners work?
Primary care clinics. So pediatricians' offices.
Okay.
I'm coming from a pediatric perspective, so that could be an internal medicine office. There are also nurse practitioners that work in specialty clinics. And you have to get, an additional training or probably on-the-job training for that. There are times when people have approached me about working in a specialty, but I don't have an ENT specialty or an allergy and asthma specialty, but they could probably teach me on the job. But I think, in the schools, that's where a lot of my most recent practice has been. So I think you can find nurse practitioners in urgent care clinics.
Yep.
All over.
And so clearly you went straight through, so without any guess, but how old were you when you finished training and were a fully licensed nurse practitioner?
Ooh, so not many people go my route.
Right.
Typically there's like a 1 or 2 year lag in between undergraduate and graduate. So I was 22, 23 when I was done.
The point of my asking this question was clearly it's a much faster pathway to career than, say, being a doctor.
Yes.
Where I joke all the time, I think I was in the 25th grade by the time I'd finished. And had I gone into primary care, there are times when I question myself, like, was all the extra training worth it? I don't know for every job that it is. If you know that you want to do something that a nurse practitioner would do, this is clearly a faster pathway for also an excellent career that does somewhat similar work.
Right. And most of what I'm doing are sports physicals. Mm-hmm. Primary care, like just regular illnesses, sore throats, ear infections, skin stuff, dermatology stuff. I do STI testing, sexually transmitted infection testing, and birth control. So I kind of have a wheelhouse that's routine for my job. So I feel pretty comfortable doing those things. Yeah. Without, direct supervision.
Right. And I'm not trying to minimize the competence and what everyone is learning in all those extra years of schools to become a pediatrician, nor am I demeaning primary care pediatricians. I just think it's important for listeners to understand there are many routes to get to jobs that you might enjoy and find valuable. And this certainly seems like a good one and a good option that maybe many of them don't know about.
Correct. And then there's also PAs. Physician's assistants do similar things to nurse practitioners, but their schooling and the way they get there is a bit different. They don't have to have a nursing background. They can come from, other 4-year degree backgrounds. And then they have a 2-year program. And I'm not 100% sure, but
Sure.
I think it's a 2-year program. I think they operate similarly, but not the exact same. But I don't know the specific nuances as to why.
No, and they seem to fit into the medical system in different ways and different roles with different jobs. But there are lots of ways to get involved in the provisions of healthcare that are not just being a doctor or a nurse. All right, so now I'd actually like to pivot to what you actually do now, because your job is fascinating, and I'm not going to try to describe it. So you tell us what you do exactly right now.
So I work for Eskenazi Medical Group, but I don't actually work in a traditional primary care setting in a clinic. I work at in the Indianapolis public school districts. I work at a high school, middle school, actually 2 high school, middle schools. And I work in like the back of the nurse's office. So they have a school nurse that does like the triaging. You come in for a headache, you need a Band-Aid, somebody has an accident. And then we also, in the back clinic, which is run by Eskenazi and not by IPS, which is Indianapolis Public Schools, is a clinic. And we do a lot of sports physicals. We do a lot of routine illness care. We do sexually transmitted infection testing. And we do a lot of birth control and birth control counseling. And I do a lot of mental health.
So with the birth control and birth control counseling, are you actually prescribing and giving birth control?
Yes.
What kinds?
So because we're in a school, it gets a little bit tricky. We have to do it after school hours. Mm-hmm. And that happens most of the time. Because we have middle school and high schoolers, that also gets tricky because there are some rules and regulations that we have to follow. So yes, we can do the birth control pill. We have the patch, and we do a lot of Depo. Depo is an injection that you get every 11 to 12 weeks. It's a progestin-only injection that suppresses ovulation and makes it so that you can't get pregnant.
And is that just a shot or is that an implant?
Nope, that's a shot. The implants, which we offer but not at school, can be done in one of the primary care clinics. Now, the nice part about where our schools and our clinics are located is that we can refer kids to the primary care clinic to do services that we can't provide in the school. We have to be careful in the school. I don't do pelvic exams in the school just for the reason that I don't want kids to feel like I'm intruding in their private and personal space while they're in the school. Mm-hmm. They can go get that done in the clinic. So we have a nice relationship with the primary care clinics with our schools so that they can receive services we can't perform inside the school.
So can a child just come in and say, I want birth control, and you give it to them?
Well, I'll sit down and talk to them. Age is a consideration. You have to, so in the state of Indiana, you can be 14 or older to consent for birth control without the permission of your parents. Now, having said that, and being a parent that has children, I would want to know what is going on in my kid's life. So I try to have a conversation with them as to, how could we have a conversation with your parents so that we can get consent from them so they know that what's going on. I don't have to have it if they're 14 or over, but I like to have it. I think it's important conversations for adolescents and their parents to have. I said, I'll say to them, hey, you know what? You're not going to get your period anymore, possibly, if you're going to go on birth control. And does your mom watch to see if that happens every month? So yes, I can do the birth control. I can write a prescription for pills. We used to have free samples, but that no longer happens as much anymore. And we can actually give them the depot in the clinic or give them the patch or prescribe the patch. If they want an IUD, which is an intrauterine device, or they want the Nexplanon, which is like a rod that goes into your arm, I will refer them out to some of the physicians and nurse practitioners that work in the primary care clinics to get that. But I will educate them about the differences on all of their options.
So if I'm hearing you correctly, it's that you try to talk to them about how they could perhaps involve their parents in these kinds of decisions, which would just make for probably better relationships. But at the end of the day, 14 and above, they can make their own decision in the end and choose what happens.
If I feel like they're engaging in really risky behavior, which has been, we've had a few instances where that's the case, and they are 14 and older and they are afraid to tell their parents, I have to weigh the pros and cons of that circumstance. Do I want my 14 or 15-year-old to get pregnant and not want to be a parent at that age? Or do I want to tell their parents and have them distrust me and have them not come back anymore? So there are a lot of things that play into that scenario, which makes me make that decision. And if I'm unsure, I will always talk to the physicians that I work with to make sure that I'm not, doing anything that's going to have a backlash.
You also said that you do screening for sexually transmitted infections?
Yes.
How often does that happen?
Quite frequently.
Okay. Is it quite frequently the screening occurs, or quite frequently you'd say also that it's positive?
Typically, the kids that come in that want to be tested have had a partner that's tested positive. Now, one of the great things about our state, we also have expedited partner therapy. So if I have a student that comes into the office and says, my boyfriend has chlamydia, I can write her a prescription or him a prescription for the antibiotic or the medication that we would use to treat chlamydia without having tested them.
And without parent consent?
And without parent consent.
Interesting.
So I can write the prescription, or if we have the medication in the office, I can actually give that to them on site.
Do you think any of this would happen if this clinic was not in this school?
No.
It seems to me like this is just common sense. Every school in the country should have stuff like this.
I think that adolescents and kids are getting access to care that, one, the parents don't have to come to pick them up at school because they're already there. Two, the kids feel comfortable coming into our office. They have amazing relationships with, and I'm not tooting my own horn, but I have some kids that come in just to say hi or.
Well, and I want to talk about that because I think a fairly large component of what you also wind up delivering is mental health. So can you talk about that for a bit?
Sure. So over the course of time, I've been at one of the schools, Broad Ripple High School, which unfortunately is closing soon. And I've, established relationships with some of these kids who come in just on a social basis during their lunch hour to say hi. But I feel like that opens the gateway to having conversations that they may not feel comfortable having with other adults in their life. And that's sometimes how I get to birth control or sexually transmitted infection testing or things that are going on at home that sometimes bring shock to my life. And that is where I find that opens the door to them confiding in me information that they may not have told anybody else. And the mental health component, we have a social worker that works with our team that's part of teen care, and she travels throughout the different primary care clinics, and she comes to one of the schools. But I find that she's only there, a half day a week, and these kids need, more consistent contact. So though I was not specifically trained during my couple of years training as a nurse practitioner on how to do mental health, I feel like I have made strides in how to just listen to the adolescents and provide some advice, I think that maybe either motherly or life lessons I've learned to help these kids, work through some tragedies and major stressors in their life.
I just can't believe that this wouldn't be an unbelievably valuable addition to almost any school, but certainly clearly is, I think, in the schools in which you guys are located.
So some of the clinics are just nurse clinics, so that most schools have nurses. And there are some that have the nurse practitioner model, which means that they can get diagnosed and treated at school.
Who pays for this? Like, is this free to the kids, or how does it all work?
So initially when I started in the schools, we were a free clinic. We were a grant-funded clinic. Over the course of time, since we do work for a public hospital, we have started billing for services. So we collect insurance information on the kids. We ideally collect it at the beginning of the school year. We can get a consent form for parents. So if a parent signs a consent form in the beginning of the year, it lists all the services we provide. And reproductive health services is listed on there. So when parents sign that consent form and fill out that insurance information, that gives us legal permission to treat their children for whatever it is they walk into our office for. So yes, we do bill for the services we provide. However, there are special circumstances when kids do not have insurance. If they need a sports physical, I feel that it would benefit them to be able to participate in sports, that we go ahead and do like a sports physical for free.
It just seems like such a no-brainer that this should be writ large, that schools all over the country should have things like this. I can't fathom how this isn't.
Well, access is just amazing.
We used to talk years ago how like they should redesign all of primary care and put it in the schools. Because of course, why not have a doctor know all the kids? You would have all of them in one place. They'd all be local. If you got sick, you could just put your kid on the bus. They could get checked.
Right. And the follow-up is great because they're at school.
Vaccination
most
rates
of the
would be
time.
100%. A follow-up visit would just be run down to the doctor. There's tons of reasons to try to think about redesigning our entire primary care system for kids based around schools. But having said that, you're certainly providing an unbelievable benefit to an area for a group of kids who desperately need it in a way that they can actually access it. It's a well-designed healthcare system, which is so rare. I almost never, ever say that in Healthcare Triage. So congratulations.
Well, thank you.
I think we're going to transition to questions. This is the part of the show where we answer your questions, and Aimee's going to do it with me today. So let us begin. Julia asks about mental health care. She's basically asking, and I'm paraphrasing her here, if face-to-face communication is ideal in terms of getting mental health care. Is it a decent substitute to use video visits or even telephone calls? Are there any studies around this? I don't think that there are any randomized controlled trials or anything like that would head-to-head pit looking for outcomes because, again, what would those outcomes be? It's so hard in general with respect to mental health to do long-term outcomes other than subjective quality of life issues. And this clearly can't be blinded in the sense that you know which of these three things you're getting. Look, here's the bottom line. If you can do face-to-face, I think that would be best. But I think video conferencing, especially in this area, could be helpful when people can't get face-to-face. And I think telephone can be helpful when you can't get either of those things. I would say anything is better than nothing. And sometimes having the ability to talk to someone else and get therapy in that manner is incredibly beneficial and probably would be even if you didn't have face-to-face. So I would not avoid the other two because that there's no evidence that they're just as good as the former. I don't know if you would.
I would agree with you.
Same answer?
Anything mental health is better than no mental health.
There you go, Julia. Nick says that he watched our HPV video, but he's 32 years old and he's never had the vaccine. What should he do? Unfortunately, Nick, you're sort of aged out. The problem with a lot of these vaccines is that once you've been exposed to the virus at all, the vaccines really don't do any good. And this is a virus that is so utterly common that it's really believed that pretty much all sexually active people by the time they reach adulthood have been exposed in some way to the virus. This is why it's so important for kids to start the vaccination and complete the vaccination series before they become sexually active. And although, lots of people don't understand that, like, well, why can't I wait? Or let's let my kids get older. If you don't do it ahead of time, it's almost always too late. So you should talk to your doctor, of course, but my bet would be that at the age of 32, they're going to tell you, unfortunately, it's too late. It's not even worth starting it. Laura asks, is there a vaccine schedule for adults? Are there vaccines you should get? The answer to that is yes. There are a number of vaccines that even as adults you need to get. I'm sure I'm even going to forget some, but I'll try to do some off the top of my head. Certainly you need tetanus boosters periodically. People who become parents or even grandparents now need boosters of their pertussis. Elderly people are now being more and more recommended to get pneumonia vaccines.
The flu vaccine?
Everyone, of course, Aimee is correct, should be getting a flu vaccine every year. There are also some varicella zoster shingles vaccines that are
and some
now being
people need
recommended
the
in elderly.
MMR later on in life. like me, when you convert to non-immune status for rubella.
Oh, there you go. And so periodically you need to get checked in certain professions as well to see if you need to get boosted in other areas. Meningitis comes up for some people depending upon what your profession is. I'm sure I'm even forgetting some out, but the truth of the matter is that clearly we've just shown there are vaccines adults should be getting, some every year. So it's absolutely something you should discuss with your doctor. Taylor asks, I'm in my 30s and I know I should have a primary care physician, but every time I try to make a new appointment, they tell me they're all full. How do I get a primary care physician? All right, Taylor, this is a question that comes across a lot. So my easiest advice, and it might not be the best, but the easiest is first, do you know a doctor? Because that's your best bet. If you know a doctor, they will recommend to you a doctor who likely is taking patients. Most of my friends who need doctors often ask me. I tell them of doctors who I think are taking. Sometimes they can get you in, that's it. But if you can't do that, there's always a second approach, and that's when I will turn to Aimee.
You can call your insurance company and tell them where you live, and they can give you a number of options in your area of people who are accepting new patients.
Yes, because the insurance companies always seem to know. Plus, I'll also tell you that if you call a healthcare system, if you know you're affiliated with a certain one, and you tell them you need a new appointment, they will find you a doctor who's accepting patients. They always have doctors who are accepting patients. And so you calling in your own individual offices probably is not going to be nearly as productive as calling the source, either through a healthcare system or, as Aimee points out,
the insurance company
system.
will also know who's covered on your plan, which is helpful.
Yep. That absolutely works. There you go. All right. Sophia writes us a long email that I'm not going to read verbatim, but is basically asking us how she should go about, or should she go about, getting a GP as she is a university student in Canada. And also perhaps does not share the same kind of beliefs about health in many ways that her parents do. I'm going to assume if you're in university, Sophia, that you're an adult. And even if you weren't, you still have some rights even to take care of yourself as an adult. But let's assume you are an adult, in which case I would say, absolutely, you should go get a GP and start to take care of your health. You are responsible for you. You should have conversations with your GP about the health decisions that are best for you. These would include obstetric and gynecologic care. These would include sexual health care. These would include mental health. These include vaccinations, just physical health, what you should be screening for, making sure everything is going fine, the tests that you should get each year. The good news is you're in Canada, where I think you're likely going to have an easy time getting insurance, it being a single payer system and with out-of-pocket payments being quite low. So yes, unequivocally, I would say do it. Talk to your friends, talk to the system, find a doctor, get one.
Well, I would just imagine that there are student health services on campus that are very accessible. So if you don't want to go far, or you don't have transportation to go far, and you want to do it, make it convenient for yourself, I would check out your student health services and see if it works for you.
And with that phenomenal answer, I think we're going to wrap this week up. Thank you again for listening to the Healthcare Triage Podcast. As you know from each time I tell you this, there's no need to support the show. We do it for love. If you'd like to support the show, you can go to patreon.com/healthcaretriage. Donate as little as $1 a month. Anything helps, but all of it helps to make the show bigger and better. This also being the holiday season, if you want to pick up some Healthcare Triage merch, you can at hctmerch.com. Of course, my new book, The Bad Food Bible, is out. It makes a great holiday gift as well, and I'd really appreciate it if you buy a copy. Tune in 2 weeks for the next episode of the Healthcare Triage Podcast.